So hello everyone. Today we are here to discuss about some basic IR hardwares. I will be taking care of the body intervention unit of this course. So I am Dr. Sushant Babbar. I am currently Assistant Professor and Chief Intervention at Dayanand Medical College, Ludhiana. And we will be discussing briefly about the nature of the body IR, what is the basic instrumentation hardware which we need on daily basis to get access into the basic procedures. So learning objectives of this course will be to identify the nomenclature, how the things are being called, what are their appearances, what are the properties, and the basic needles, wires, sheaths. These are many needles, many wires, everything is available, and what is needed in which cases. So we will be briefly understanding these things. And we will recognize the interrelationship, which wire in which needle, what is the gauge, what is the French, and everything will be discussed. And we will also which catheter and which needles to be used in which cases to start with. We will have a brief conversation regarding. So first, we will be discussing about the non-vascular cases. What is the fine needle aspiration cytology, biopsy, drainages? What is the trocar technique, Seldinger technique? What is the instrumentation required in both? And once we understand drainages, we are good to go with what are the percutaneous transbiliary interventions, PCNs, ureteric interventions, DJ stenting, and everything. So to start with the fine needle aspiration cytology, fine needle aspiration cytology are generally procedures which are performed via small needles. So these are 18 to 25 gauge needles and which are used to carry out the small samples which is carried within the hub of this needles. So multiple FNC needles are available. Most commonly used are the spinal needles, which are type of a Quincke needles. These have a beveled tip and a hollow inner space in which the tissue is collected. Another needles are the Chiba needle. Now, the basic difference between the Chiba and the Quincke type of the needle is the bevel tip angle. So, Chiba needle has an angle of around 30° to 45°. However, the Quincke needle has an angle of 20°. So, what actually difference makes this angle is the maneuverability. So, once you insert the needle in the body, we can change the direction more easily with the Chiba needle as compared to the Quincke needle. And these are available in multiple sizes 9 centimeter, 15 centimeter, 20 centimeter, as per the depth of the lesions. So these needles can be selected accordingly. And these are also available in multiple sizes compared to the thickness. 18 gauge will be the thicker one. As we increase the gauge, the size of the needle decreases. So size of the needle is larger if the gauge number is lesser. So 14 gauge needle is a more thicker one. 26 gauge needle is a more thinner one. So another type of needles we have is the trocar needle and the Turner needle. So trocar needle, these all needles vary based on the shape of the tip. So trocar needle has a three diamond shape, a three-sided sh- uh, configuration, and this have a less maneuverability as compared to the Chiba needle. Turner needle is almost same as the trocar needle with a bevel tip. Chiba needle has the maximum maneuverability. Another is the Westcott, Francine, and the Quincke type of the spinal needle. So we also have in our hand is this kind of a Chiba needle. If you all can see, uh, so this is a Chiba needle which is a have an angle of around 45°. So next we come to the biopsy needle. So when we talk about the FNAC needle, FNACs are generally a small needles which are of sizes 22 to 25, 26 gauge. So these needles are used for having a small material. So gives us a rough estimate of what is the tissue character. So whenever we need to use a larger sample, we always need to take a biopsy. So biopsy needles are generally a thicker one. Biopsies are taken from 9 gauge, 11 gauge, 14 gauge, 16 gauge, 18 gauge, and up to 20 gauge. So these needles are characterized into small caliber, middle caliber, and the large caliber needles. Small caliber needles are 21 gauge to 25 gauge. Middle caliber are 18 gauge to 20 gauge, and large caliber are 16 gauge to or larger, or 14 gauge or 9 gauge. So biopsy needles are currently of two types. Biopsy needles, we have a side cutting and a end cutting needles. So in a side cutting needle, so I will try to show you. So if we can see, this is a biopsy gun. This is a side cutting biopsy gun. So this has an end plate within it. So this is a 18 gauge side cutting biopsy gun in which the sample is collected. So as we can see from this diagrammatic representation, this is a side cutting biopsy gun which is advanced from within the needle, and the tissue sample is targeted, and this tissue is collected over this side end plate. So this is a larger material as compared to the FNAC needles, and this tissue is processed for pathological purposes. And another type of the guns are, this is a cylindrical end cutting biopsy guns, so which carry a complete hollow circle and gives us a more sample. So these biopsy guns can have the major bulk of the tissue which can be taken with the same kind of the needles. So these provides a larger core. So biopsy guns again vary from different sizes compared to the what is the target area. So normally if we are doing a biopsies from a liver or a renal, we are tend to use an 18 gauge biopsy needles. But if we change to a breast biopsy, so what are the guidelines is we have to use a 14 gauge biopsy guns, and we have to take a multiple course. Like at least 4 cores are required of a 14 gauge biopsy gun for a breast biopsy. As compared to the liver, the biopsy criteria are we have to use at least 2 centimeter of 18 gauge biopsy sample, and it should have a more than 11 portal triads on a slide. So that is the adequacy of the different organs as is needed to get an adequate sample. So depending on the organ, depending on the gauge size, and depending on the lesion, we tend to change the biopsy sizes, the needle sizes, and the length of the biopsy guns. So this is a manual biopsy needle. Manual biopsy needles are a kind of a semi-automatic needle, which we have a control to advance over it, and another is a fully automatic needles. So these guns do not have a control. These just fire behind the lesions. So again, we will try to show you what are the semi-automatic and what are the automatic biopsy guns when placed side to side. So this is a semi-automatic biopsy gun. So when we are using a semi-automatic biopsy gun, these semi-automatic biopsy gun have two parts. So this is a trocar, uh, which can be advanced to advance the end plate. So this end plate is this control is there to advance the end plate. So this step is not an automatic one. So this is known as a semi-automatic biopsy gun. And once you reach the target, you advance the needle into the target and then fire it. So this will have a sample within this end plate. As compared to the automatic biopsy gun, now this biopsy gun, we do not have this advancement capability. What we have shown in a semi-automatic gun, this is a semi-automatic and we can advance it. However, when we use an automatic biopsy gun, we just load it, and we do not have this capability of advancing it selectively under ultrasound guidance. So we can just place it and fire it. So this advancement capability, when is not there, it is the automatic gun. And when we can have this control over it, it is a semi-automatic gun. So mostly two type of biopsy guns are available. One is the semi-automatic one, that is the manual biopsy needles, and another is fully automatic, in which the side plate is also advanced automatically, and then the firing is also done automatically. So these are known as a fully automatic biopsy guns. And third is these both were the side cutting, in which there is an end plate. However, we have another biopsy gun which is a completely hollow. I have shown you an end cutting biopsy gun. So there is no side plate in this kind of biopsy gun, and still we do not have a control over it. So when we do not have a control over it, we still have to advance. We just place it across the lesion, and under ultrasound guidance, when we fire it, it just goes beyond it. So there is no control how we can advance. So again, this is automatic, but it is a complete hollow thing. It do not have a side plate. So it will have a complete cylindrical core. So we have a basically three type of biopsy guns. One is the semi-automatic, another is automatic, and again automatic of two types with side cutting, and another is a end cutting. So now another technique is a coaxial technique. So what is the coaxial technique? Coaxial technique is when we advance this biopsy guns through a coaxial needle. So we have this coaxial needle. When we advance this biopsy gun from a coaxial needle, then definitely this is known as a coaxial technique. So what is the benefit? If we want to take a multiple course, like we want a breast biopsy to be done and we want just a single prick to have been done in the patient and we want multiple course. So what we do is we do not directly insert this biopsy gun. What we do is we take a coaxial needle. So again, this is a diamond cut trocar type of a coaxial needle, which has a three cuts shape, a diamond shaped tip, and through which a biopsy gun is being advanced. And this biopsy gun, once we place a needle, we advance a biopsy gun from this coaxial needle. And once we advance this coaxial needle, so this is placed just behind the lesion and good to fire. And we take out the sample. And similarly, we can again advance this biopsy gun after loading it. And again, second sample, second core can be taken again. And like this, after placing just one needle, we can take multiple biopsy samples from within this needle. So this is known as a coaxial technique. This technique is very useful when we do we have to take a multiple biopsy samples. So we use a coaxial technique. So now we are coming to the drainages. So drainages started when we started using this Seldinger technique. So it is very important we know about basic of the Seldinger's technique. So Sir Swan Ivar Seldinger devised this technique in 1953 for a vascular procedures. So what they used to do is they do a double wall puncture and then withdraw the needle. And when they see a gush of blood coming out, they advanced a guide wire. And then this guide wire was used as an access over which a sheath or catheter was advanced. But now what we use is a modified Seldinger technique. So this diagram depicts a modified Seldinger technique in which we use a single wall puncture. We do not use a double wall puncture because now it is ultrasound guided. Previously, the actual Seldinger technique was advanced for fluoroscopy guidance only, and these were not done under ultrasound guidance. But now the things have changed. Now we use a ultrasound guided interventions. So when we do ultrasound guided single wall puncture, we insert a needle. Then second step is through that needle, we put in a guide wire. So what exactly is this ligand technique? Again, we have this needle. So again, we are using this trocar type of the needle. So once we use this needle, we place the needle into the desired cavity, structure, vessel, anywhere. We can insert this needle. We can remove this stellate. And after removing the stellate, we can insert the wire from within. So this is the basic wire. So this wire can be used to insert through this needle. And once we insert this wire through the needle, now we have access to the cavity. Now this needle is being removed. And now we can use this wire as a guide way to introduce our catheter, dilator, or anything we have. So these are basically, it act as a guiding measure and we can advance our other materials or catheters over the wire. So these makes the basic of the drainage procedure. So modified Sendinger technique is used for gaining a vascular access or gaining access into the liver abscess cavity, splenic abscess cavity, or any drainage procedure we want to do in our body. So modified Sendinger technique is being used. Now, another method, another we have to another interventionist was Sir Cope, which introduced this loop technique. So what he did, he introduced a looped catheter so that when the catheter is mounted and it is within the liver abscess or splenic abscess or pancreatic abscess, it do not come out. So he introduced the loop technique. So this loop was introduced, and this helped the catheter to stay inside and have a better drainage. So when it was done, it resulted in a complete spectrum of non-vascular interventions. So by the grace of Sir Seldinger, so we are using these drainage procedure to introduce even higher or larger bore catheters, which were initially being done by a surgical peoples. So drainage is divided in a two-step procedure. There are basically two techniques. One is a trocar technique. So what is the trocar technique? Trocar technique, if we use this catheter and it has a needle in within, and we introduce needle and the catheter at a one-step procedure. So when this thing is done and using a needle and catheter as a one-step procedure, this is known as a trocar technique. However, what I have shown you is we first introduce a needle, then we introduce a wire over it, and then over the wire we can have a gradual serial dilatations. If we want to place a 10 French catheter, then we can have a 10 French dilatations and gradually increase it. So this Seldinger technique allows us to place non-traumatically even a larger, wider bore drainage catheters within the body. So these are the basically a pigtail catheters. On the left side, this is the pigtail catheter. It has a pig formed at the end of the catheter. These are the male cot catheters. So male cot catheters are tend to shown to have a better drainages and more commonly used as a wider bore catheter in the pancreatic collections, which are more thicker one. And these are the ring biliary catheters. Ring biliary catheters, what is a ring biliary catheter is has a pigtail configuration at the distal end and have multiple holes. So what this multiple holes is, how this multiple holes helps, this catheter is generally used in a percutaneous drainage of the biliary system. So when ring biliary catheter helps us, we cross the narrowing, considering that this catheter is placed across the narrowing. So we will have some holes which are proximal to it. We will have some holes which are distal to it. So this catheter, the bile will flow from these holes, and assuming the narrowing at this point, it will cross the narrowing and drain into the duodenum from these holes. So ring biliary catheters helps to bridge the narrowing from both sides. So we have holes both proximal and distal to the obstruction, and these catheters helps again have the flow to the normal channel across the narrowing. So this bypass the basic obstruction. Now, what is the other drainage catheter which are available? These are the tunneled catheters. So these are basically kind of a palliative care catheters which are available, and these are home care catheters. So what are tunnel catheters? Tunnel catheter basically we drain the ascitic or pleural fluid from this space and make a tunnel. And after a formation of tunnel, this catheter comes out of the skin. So I will just show you a case of a tunnel catheter. So this is kind of a tunneled catheter. This is a long tube which is inserted into the body. This is the tunneler. This is the again needle which is used. These are the sheaths. So we will understand the basic Seldinger technique also. So after giving a local application, what we do is we insert a needle. So after inserting a needle, so we have a confirmation that there is a flow of ascites. And once the confirmation is there, we inserted this guide wire. Now, this guide wire is again a method which is used by the Seldinger technique. And then we make a tunnel from this entry point to the exit point. So when this tunneler is used, so we make a this is the 2 point. Now this is the exit point of the catheter. This is the entry point of the catheter into the cavity which is being used. So after doing a tunnel formation, what we do is we insert a sheath and introduce the catheter. So now this is the place where the catheter has gone into the body, and this is a place which is the catheter has come out from the skin. And this much area is a tunnel. So this tunnel helps to reduce infections and helps the drainage of the fluid at the home care basis. So these are basically the catheters which are used for a home care basis, for which needs a drainages of like 6 months, 8 months, palliative care. So these catheters can be used. So we have discussed about male cord catheters, pigtail catheters, J-tip catheters, ring biliary catheters, and these are the tunneled catheters. So basically, the non-vascular procedures, be it the PCN, be it PTBDs, be it liver abscess drainages, pancreatic drainages. So these multiple catheters comes in various sizes. So these sizes can be used according to our requirement. If we think we have to drain a pus or a very large thick collections, we can go for a 16 French, 20 French, 30 French, or a larger high bore catheters. And we need to just drain a fluid, if it is a clear fluid, if it is a tubercular, if it is a normal ascitic fluid or pleural fluid, which is exudative in nature, and there is no septation, no blood, so we can use a smaller catheters like 8 French or 10 French. And if we want to do the similar thing in a pediatric population, we have as small as 5 French, 6 French, 7 French. These catheters can be used from day one of birth to like any according to the indications. So all sizes of catheters are available, and Seldinger technique provides us with the very safe technique of introducing these things. And coaxial technique for biopsy gives us from minimal pain, single puncture, multiple biopsy samples. So whole in all, these basics of FNACs, biopsies, drainages, a basic of the needles, how the guide wire is introduced into these needles, how the coaxial technique works, and what is the Seldinger technique, gives us a brief about how these procedures are being done in a non-vascular cases. So again, moving towards vascular procedures. So vascular procedures, again, as we discussed, these were invented by Sir Dotter. So what Charles Dotter did was, he was doing a diagnostic angiography of the renal artery stenosis, and he passed a dilator into the iliac artery. And when he took out everything, he saw that the iliac artery, which was previously occluded, was showing flow across. The flow was seen across this occluded segment, and it got dilated, and there was resumption of the flow. So he did an intentional. This was an accidental thing which was done, and then on 16 January 1964 the doctor and Sir Judkins performed the first intentional percutaneous transluminal angioplasty on a superficial femoral artery. So this was a patient with almost narrowing at the superficial femoral artery. And what he did is he introduced catheters through superficial femoral artery, did a percutaneous dilatation, and this was known as a endoluminal surgery. So how this vascular intervention radiology got its birth is from the this accidental procedure of the iliac case, and then a intentional case of a SFA angioplasty. And since then, many advancements has been done. So what we now basically we will be discussing is, we have seen the needles, we have seen the catheters, we have seen the wires. Now we will understand how these, what is the gauges, what is the French, what is the wire diameter, and what is the catheter sizes we tend to see and use in the intervention radiology. So needle diameter is generally measured in gauges. So we have again discussed that lower the gauge, the larger the needle. The 16 gauge needle will be larger and 26 gauge needle will be smaller. So if we want to use a drainage which is thick, we will use a wider bore needle like a 16 gauge. And if we want to just drain a simple fluid, then we can use a 20 gauge needle or even a 22 gauge needle. Similarly, a fine needle procedure, fine needle aspiration will be done with a smaller gauge, like 22 to 25. And if we want to take out a pus, again 14 gauge or 16 gauge. Now coming to the catheter and the sheath diameters, these are measured in another unit known as French. So what is French? One French is 1/3 of a mm, and 0.013 of inch. So whatever catheters, like we have seen a drainage catheters, we have been talking about this French, 10 French, or 14 French, or 16 French. So these French sizes, as we increase the French sizes, the bore of the catheter, it becomes more larger. So what we have is this is a smaller 10 French catheter. So if we have a larger catheter, it will be more wider, more thicker. So one French is 1/3 of an mm. This dimensions are very important to learn. And how the wires are being measured, we introduced this wire. This was a 035 wire, which I have showed you previously. And there are multiple wire sizes which are available. There are 001 4-inch, 001 8-inch, 002 5-inch, 003 5-inch. And what is the importance we will be discussing again. So importance of these wires is it tells us about the compatibility. The compatibility of the needle and the wire is very important. So these needles are color coded. 16 gauge are again gray size and going up to the 26 gauge, which are the brown, which will be the brown needles, and can be used for smaller targets, and larger again can be used for bigger targets. For local anesthesia, again, we will be preferring a 25 or 26 gauge needles so as to give a minimal pain before actually doing a procedure with a larger bore needles. So we give a local anesthesia to numb the skin and the tissues which are painful by using a smaller gauge needle so that the patient has a minimal pain. So ideally we should use local anesthesia using a 25 or 26 gauge needles. And again, and the compatibility and the area of interest is very important. A 22 gauge needle will accept a 0.018-inch wire, and a 18 gauge needle will accept a 0.35-inch wire. So why this is important? Again, we have shown you the Seldinger technique in which we were using the needles and the wires. So if this is a needle, this is a 17 gauge needle. So I know that this 17 gauge needle will accept 0.35, 0.38 inch of the wire. So I have with me is a 0.35-inch of the wire. So this wire is now compatible to go inside this needle. So if this is compatible, then only the procedure can be completed as we can slide out this catheter. But if we have a non-compatible needle, like this, I have a needle. This is compatible with 0.25 wire, and I have with me is 0.35. So when I try to insert it, it will not go. So again, if I have introduced this needle into abscess cavity, I want to proceed with the Seldinger technique. I want this guide wire to be placed so that a catheter will be placed over this guide wire. So if we have a non-compatible needle, which is compatible with 0.25, and I have a guide wire which is 0.35, so I cannot complete the procedure. So compatibility has to be understood, and we should know a hardware knowledge that this specific needle will be compatible with this specific wire. And if I have to complete the procedure, I have to use a compatible needle. So this needle is compatible in 035. So this is accepting the guide wire. And now over this guide wire, I can place my catheter and complete the procedure. Now this catheter can be slided over this guide wire and the procedure can be completed of the placement. So once this catheter is inserted, so we can have a access into the drainage cavity, and over this we remove the guide wire and this catheter is now in place. So the compatibility is very important. If we use a non-compatible needle with a thicker wire, we cannot proceed ahead for the placement of further catheters and the wires. So 22 gauge needle will accept a 0.18-inch wire, and if we use 18 gauge, it can have a 0.35-inch wire acceptability. So multiple venous access, arterial access, or drainage access for percutaneous interventions, these needles and wire should be matched for the compatibility. If these are not compatible, we should change the needles, and one should test these things outside only before inserting this needle into the patient. So again, these are the multiple needles. Needles are again color coded. This is the cheaper needle, which is black color. This is a 21 gauge needle, which is a trocar type. These are 16 gauge, 18 gauge, 20 gauge, 21 gauge, multiple different sizes of the needle. So 25 and 26 gauge needles are used for local anesthesia. Normally 22 to 26 gauge needles are used for FNAC. And in general, we use 11 gauge to 18 gauge to 11 gauge to 20 gauge needles for biopsies. And similarly for vascular access, we use a 18 gauge needle through which a copendral wire 035 can be inserted. And if we are gaining access into the peripheral artery like radial artery or a pedal access, we use a micro puncher set which accepts 021 kind of guide wires. So everything depends on which access we want to take, how big our target is, and we can use our needles and wires accordingly. So needles are again of it can be a single wall type, trocar type, chiba type. We have discussed it again. Single wall type is we do not have a stillet within it. It is a single bevel which is seen, and it is a hollow needle. Trocar I have shown you again and again. This has a three-tip diamond cut at its end with a hollow needle. So this is a stylet, and this is the trocar type of needle, which is a two-part. So inner sharper one is a stylet which can be removed, and outer one is a hollow part. So this is the trocar type needle. Chiba type again available in beveled edges with multiple sizes, and mostly all these needles are now corrugated at the end, so I have to have a better visualization on the ultrasound. Now coming to the guide wires. So what the name suggests, the guide wires generally guides the catheter. It helps to place a catheter at our wanted location. So what we did was we insert a needle into our target location. Now we insert the guide wire. So guide wire is placed to the target area. Now the catheter will be over the guide wire and it is guided into that target location. So guide wire guides the catheter and helps in the placement. So guidewires are referred to in hundreds like 038, 018, 035, and these sizes should be selected to match the diameter of the tip of the catheter and tip of the catheter or tip of the needle. And larger guide wires will tend to jam the catheter, and smaller guide wires tend to leave the space and will have a lesser support. So adequate compatibility between wires, catheters, and needles is very important so as to have a free flow of the hardware and to a smooth interventions. So what is a guide wire made of? So these guide wires are kind of non-traumatic guide wires. These have a central stiff core, which is a mandrel core, and it has a coiled springs outside and again a coating outside, which can be hydrophilic coating, it can be a hydrophobic coating. So hydrophilic coating, it is a water friendly coating. Hydrophobic will be it is repellent to the water. So mostly 90% of the guide wires which are being used in our interventions are hydrophilic. So we need to keep that guide wires wet. And there are multiple kind of guide wires which as we practice ahead, we tend to see these are the multiple. It can be a straight tip guide wire, it can be a J tip guide wire, it can be a guide wire which have ability to change its stiffness, that the floppiness can be extended beyond it, and it can be a smaller core that the springs are just at the distal and the mandrel core are seen behind. And these guide wires again are used based on what is our target location, what is the target artery, what is the target vessel we want to go ahead. And these can be solid or wrapped, coiled or braided as seen. And these are selected based on the pushability, steerability, torque, and its opacity. So these are the basic terminology we use to define the guide wires. So pushability is one thing, the amount of force which is needed to advance the guide wire from the catheter. So we want that once we push a guide wire through the catheter, it should go up very smoothly, and with the force we applied, it should be reflected in the movement. And steerability is as we ability to responsiveness as we navigate through the vessels. It should go into the tortuous vessel. It should be easily steerable. And torque is one thing. Like I rotate a guide wire at its one end. If I rotate a guide wire at its one end, and that other tip of the guide wire should rotate in the same quantity and the same proportion. And if it is seen in the same proportion, this is known as the torqueability. If the guide wire has a one-to-one torqueability, like I have rotated 180 degree on the one tip in my hand, the distal tip of the guide wire is also rotated by 180 degree. So if it is one-to-one, it is the ideal one, and it defines the torqueability. And how well the guide wire is seen is opacity. So based on the tip configuration, again, it can be a straight tip or J shape. These can be shaped according to our needs also. And length of the guide wire. These are available according to our need. If we want to go to a very distal, we are taking a femoral access and want to reach to brain, then we need a larger guide wires, larger catheters. So these guide wires are available from various sizes. If we need a smaller area of interest, we just want to go from a femoral puncture to a radial one, or we want to do a liver abscess kind of thing. So we can have a guide wire which is a smaller in length, so is it easier to manage. So, but if we need a larger procedure and larger hardware is required, the length can be extended. So guide wires are available from 30 centimeter to 260 centimeter and up to 400 centimeter also if we are doing a GI procedures. So if we want to place a duodenal stent or tracheal stents or esophageal stents, a larger guide wires are also available. So average guide wire which we use is approximately 180 centimeter to 260 centimeter. 260 centimeter wires are over which we can change the catheter, the whole of the catheter. 100 centimeter catheter can come out and we can introduce a new catheter. So 260 centimeter guide wires are known as exchange guide wires. So wires again are depending on the diameter, stiffness, hydrophilic and non-hydrophilic complication. These can be the excess wires. So what I have with me, which I have shown you, is the excess wire. So we do a needle puncture, we place a guide wire, and we place a sheath over it. So this is known as the excess wire. This is not used for advanced vascular procedure like going into the celiac artery or renal artery, for which we have to use a maneuver wire. So maneuver wire is a very soft wire which is advanced from the catheter to uh, hook the from the catheter to hook our target vessels to go into the celiac axis to SMA or its further branches or even the carotids or intracranial vessels. We use a maneuver wire to guide our catheters, and these are very floppy. These are very soft. So our actual hardware or sheets or stiffer material will not be easily carried on this maneuver wire. So what we do is we take a maneuver wire, we take a smaller catheter over it, we take out our maneuver wire and introduce a rail wire. Now rail wire is kind of implants wire, Lunderquist wire. These are the stiff wires. So what they provide is they give us a support to carry our hardware. Our hardware, our stunts, our balloons, our sheets, which are everything is carried over this wire. So initial is the excess wire. We take a excess wire to gain access into the vascular system. Then we use a maneuver wires to go into the target vessels. And then if we want to stunt it, we want to take our larger bore catheters, we want to take the larger devices, we need to exchange it with a rail wire. So rail wire gives us the support. So again, these can be hydrophilic and non-hydrophilic. So hydrophilic wires are useful in fluid environment, and when a narrow area must be transversed, these are very steerable as compared to the non-hydrophilic. Again, everything what we choose comes on whatever target is. So we are using a lesser narrowed area we want to cross. We will be using a smaller caliber guide wires with a more steerable nature with less injury potential. So we want to go across a narrowing like renal artery stenosis, we can use a 014 or 018 guide wire. But however, we just want to go across in aorta, so we can use a 035 wire, which gives us more support and definitely more the thick, more easy to carry a catheter across it. So both hydrophilic and non-hydrophilic wires are useful for vascular work and even for both non-vascular work, like in PTPDs or we want to do a DJ stenting. And must use at least a 22 gauge needle or 3 French catheter for O1. Again, compatibility is very important. We need to have a compatibility. So if we are using a 3 French catheter, then we cannot use a 035 guide wire. And similarly, if we using a 22 gauge needle, again we cannot use a 035 guide wire, we had to use a 018 guide wire. So compatibility has always to be there. And if we want to use a 035 guide wire, we need to change to a 18 gauge needle or a 5 French catheter. So 5 French catheter, again as we said, French is 1/3 of mm. So 5 French is a larger than 3 French. So 5 French catheter is compatible with 035 guide wires, and 3 French catheter is compatible with 018 guide wires. So we can get initially access with the cope wire, which is the excess wire, and then exchange with the 5 French catheter and use a maneuver wires. And when we want to take actual stunts and balloons across it, we can use a rail wires. The rail wires can be of the implants, New Yorker, Benson, Lunderquist, or Roadrunner. These are the stiff guide wires which are available in both 018 and 035, and both categories, hydrophilic and non-hydrophilic. Most commonly, what we use is a hydrophilic both stiff and non-stiff wires, which are of more usage. And most commonly used in the non-hydrophilic is the implants in the Lunderquist wire, which is commonly used. So one of the most common used wire is a glide wire. Glide wire is a wire used given by the company Termo. So it is available in both straight tip and the curved tip. Depending on our need, we can use it, and it easily glides through the narrowings through the vessel. And it is a hydrophilic wire, and it has to be kept wet all the time so as to maneuver. So it easily maneuvers across the target areas through biliary systems, through portal systems, through vascular system. If we want to maneuver thing, it has a very good steerability. And another is the stiff glide, which is available. Again, it has a kind of a rail wire which is available, and this rail wire gives us a support. But this rail wire is a hydrophilic one, and implants is a second rail wire, which is a non-hydrophilic one. So depending on our need, we can use, and depending on the length of the wires available, we can use these kind of wires. And the cope wire is the again excess wire. Multiple wires are available: Benson wire, Rosen wire, Lunderquist wire. Lunderquist is one of the incredibly stiff rail wire, which is commonly used in procedures when we are dealing with the larger, very high heavy stunts like in the aorta, TIVAR or TAVI. We want to take our very wide bore stunts. Then the Lunderquist wire is needed to give a major support for it. So this is a example of an implants extra stiff wire on one side, and another is a Termo wire, which is a hydrophilic black coated polyurethane jacket, and this is a hydrophilic wire, which is normally used as a maneuver wire. And so this is the most common used maneuver wire, and this implants is the most common used rail wire. And cope wire, what we have in our hand, is the most common used excess wire. So these three wires is the most commonly used wires, and depending on the length, this is the 260 centimeter, this is the exchange length, and it is also available in 80 centimeter, 145 centimeter, 180 centimeter. Depending on your area of interest, we can use this stiff wire to place our catheter uh, or this drainage catheters in place. So safety test is three tests we should be knowing, that determining the flexibility. The end of the guide wire should be flexible, and while bending it 180-degree, it should not uh, kink or crack so as the tip of the guide wire do not injure it. And visual inspection should be done that the spring of the guide wire is in place and it is not detachable. And checking the core by giving a slight twist, like just giving taking the wire and pulling it on the both sides, so as the central core is felt and it is integrated. And it is, we do not want that this wire goes in and then it gets stuck in the body between the needle of the catheter and we cannot take it out. So safety, these three safety tests of the guide wire should be checked. And another is shearing and the kinking of the guide wires. Shearing is if the wire is retracted too forcibly, so it gets too forcibly through a bladed needle, so it gets stuck at the end of the needle, and the wire can shear off the upper. As we shown, the wire is made up of two parts. The central was a central stiff mandrel core, and outer was the coils. Now the coils can get stuck in the tip of the needle and be sheared away. And this shearing of the coils will disintegrate the wire. And shearing can happen with cope wires, or it can happen with almost any wires. So whenever we feel that there is a shear happening, we need to take the needle and the wire collectively outside. And another is the kinking. And if you try to force a stiff dilator or a stiff catheter, which is very hard, which is not bendable, so what it will do at a point of acute angle, it will just kink the wire and it will make it very difficult to advance it. So this kink should be taken care of. So how we can take care of this kink? So either we can just take this guide wire out and insert a new guide wire now from this catheter, or we can just advance the kink into further into the lesion so that the catheter slides over non-kinked part. Or this guide wire can be retracted partially back into the catheter so that this acute angle at where the angle is the kink is not there at this acute angle. So multiple solutions as we practice, we have it. But these two things of the guide wires are faced routinely, and this should be taken care of. Now, another aspect which we have discussed this catheters, we have discussed about wires, we know about needles, we know about the maneuver wires, we know about the rail wires, we coaxial techniques. Now, the most important part next is the sheaths. For a vascular procedures, once we insert a needle, now, once we insert this needle into the vascular femoral artery or radial artery, we insert this guide wire. So we discussed about these guide wires, what all the guide wires we required. Now, over this guide wire, we will be requiring to insert a excess sheath. Now, sheath, what sheath is? Sheath gives a, this is a example of a sheath. So this is one way, this is a safety valve is applied on one end of the sheath. So this diaphragm, this safety valve do not allow the blood to come out. So this is a kind of one-way thing, and we can introduce our catheters or wires from this sheath directly into the femoral artery. So these sheath also comes in a variable sizes. These can be four French sheaths as red. This is what in see in picture is a 5 French sheath. So again, 5 French sheath will accept a 5 French catheter. 5 French sheath will not accept 6 French or 7 French catheter. Again, the compatibility is a big thing which should be looked before we insert a sheath. If we tend to place a stunt which is a 6 French compatible, then we should start with a 6 French sheath. So later on, when we insert a 6 French catheter or 6 French stunt, it should go from that sheath. So a larger hardware will not go from a smaller sheath. So compatibility of our procedure is checked before taking the access. If we want to insert a larger catheter, we again have a larger sheath in place. So sheath assembly, it is always flushed and dilator fits in it, which slides over the wire. And sheath is the French size is the measure of its inner diameter. So a 5 French sheath is a sheath which will accept a 5 French catheter. Catheter has a French diameter of its outer side. So if this is a catheter and this is a 10 French, it is from the outside, it is 10 French, it is not from the inside. However, when this French is denoted for a sheath, it is from inside. So if if we consider this is a 5 French catheter, so this is outer will be 5 French and this sheath is a 5 French from inside, and this will generally accept this catheter. So for sheaths, it is always the inner diameter. If we take it as an outer diameter, it is approximately a 4 French sheath will have an outer diameter of 6 French. So what we need for a clinical purpose is an inner diameter always. So for sheaths, it is always inner diameter. For catheters, it is always the outer diameter. So we check the compatibility of these things by this French size. So 4 French are red, 5 French are gray, 6 French are green, 7 French are orange, 8 French sheath are blue, 9 French or larger are black. And we can have sheets like 10 French, 12 French, 14 French, 20 French, depending on our size and the requirement, what is our requirement. So we can have sheets according to that. Now coming to the catheters, once we gain access into the vascular system, we inserted a needle, we inserted a guide wire, then we inserted a sheath. Now we want to go from a femoral artery or radial artery to suppose a celiac artery. So one should guide our catheter and we need a wire to reach from femoral artery to common femoral artery to aorta and at the level of celiac artery at the level of D12 or L1 vertebra. So outer size of the catheter is again French and diameter of the end hole is described in hundredths of an inch. So that tells us which guide wire will be supporting in the which catheter. So 5 French we have studied that it will support a 035 guide wire. So end of the catheter will always have a mention that this hole is in this much inch of thing can go from this much of hole. So again, this guide wire can go from that particular catheter. And length of the catheter is usually 65 to 100, and we have even larger catheters, 125 centimeter available, and various shapes are available. So what is the ideal catheter? Ideal catheter, again, it has a better torque control, it has good strength, good radio opacity, very flexible, it has an atraumatic tip, it has a low surface frictional resistance for good trackability, and catheter should always be flushed and select catheter based on the sheath size. Shape of the catheter to be chosen based on the anatomy of the artery to be hooked. And catheter should always be passed over the wire. These maneuver wires are the wires which guide the catheter and avoid kinking the catheter. And this should be discarded if there is any obstruction due to the previous use. Now, there is numerous catheter types. And just showing you, these are the multiple catheter types. This is a pigtail catheter, which has a pig. With this can be inserted for aortograms, aortograms or for the drainage procedure. Like in aortograms, we do not want all the contrast to be coming from a single hole. So we have a multiple holes, and we need a large amount of contrast to opacify whole of the aorta and its branches. So the pressure exerted is distributed from these multiple holes so as to have a good aortogram. So aortograms are never taken from an end hole catheter. Aortograms are always taken from a multi-side hole catheter so as to accommodate a large amount of contrast with a less pressure. Otherwise, if we use this kind of catheter, which is an end hole catheter, whole of the contrast will come from this end and it will project into the aorta wall like a jet. And a jet with that much of speed can injure a aorta, or it will have a less of the opacification also. So these are kind of a pigtail catheters which are normally used for aortograms. These are end hole catheters. This is a cobra catheter, and these are depending on the shapes we have. This is primary curve, secondary curve, tertiary curve. So these are the multiple catheters, which is depending on the shape we can have. If we want to go into the celiac axis, we can use a cobra catheter or Siemens catheter. If we want to go into the subclavian or carotids, we can use a Picard catheter or vertebral catheter. And if we want to use go from a one iliac artery to the another contralateral iliac artery, we can use a cobra catheter, or there are dedicated U-shaped catheters which are available, what is known as uterine catheters, RUC catheters. So multiple shapes of the catheter are available depending on the which artery we want to hooks. So there are Judkin's right catheter for the RCA and coronary catheters. So everything is available. So main distinction is end hole versus side hole. Again, end hole is used for like if we want to take a run from a celiac artery selectively, then end hole catheter. If we want to aortogram, we will use a multi-side hole catheter. Then selective versus non-selective. Again, pigtail will be a non-selective. Selective will be the end hole catheters. And again, glide versus non-glide would be the depending on the coating and diameter and the shape. So many come in hydrophilic and non-hydrophilic forms. Most commonly used are the hydrophilic one, and we have a flush catheter and a selective catheter. So this is a flush catheter. This is a select. These all are selective catheter. Now the shapes of the catheter can vary. This is a Siemens catheter, which is straight when inserted, and then we take it into the arch of aorta and then forms it shape like a reverse shape. So this is a Siemens catheter. This is an angled catheter again. This is a MPA catheter. This is forward facing. If you want to hook a artery which is forward facing, we use this catheter. However, we use a cobra catheter if we have a almost this kind of angle. And if it is a too acute angle, we can use a reverse catheter to hook this target vessel. So this diagram illustrates us multiple catheter shapes are available, and these are always chosen depending on what is our target vessel and what is the anatomy and angulation of this target vessel for which we are doing this procedure. So these can be the forward facing. These are the forward facing catheters. So forward facing catheters are the glide cath, vertebral, multi-purpose catheter. These are the reverse facing catheter which are used to hook a very acute angled vessels. Like if the in an older age group or in a kind of patient is a very acute celiac or SMA or inferior mesenteric arteries, then again Michelson catheter is reverse kind of catheter. Cobra catheter, SOS catheter. These all catheters come in a different shapes. And this is a RUC catheter. You can see this RUC catheter has two curves. So the two very acute curves. So this helps to cannulate across the second contralateral iliac and guide this catheter into the internal iliac and to the uterine. So this catheter is made according to the shape of the target vessel which we want to go. So depending on this, the pigtail can be used for aortograms for larger veins. Straight flush catheters can be used, curved flush. Flush catheters always have a multiple side holes. These are not a end hole catheters. The end hole catheters are used for like Cobra catheters or Michelson or Siemens catheter are used for selectively cannulating and taking their corrective arteriograms like celiac arch, superior mesenteric, inferior mesenteric. So these are various common uses. Which catheter is used in which arteries? RC catheters are used for renal arteries. Cobras can be used for even single catheter can be used for multiple arteries. Like Cobra can be used for uterine artery also and for celiac axis also. RUC catheter can also be used for uterine artery. SIM catheter can again be used for multiple arteries. So it depends on every patient has its own anatomy, own angulation, and we select the catheter according to the shape. And if we do not have a dedicated shape available with us, we can always have a steam. We can just by heating the catheter from away from like 10 seconds or 30 seconds, we can then dip the catheter, and this shape is being retained by the catheter. And these catheters can be selectively used on case to case basis to further guide our hardwares. Now again, any catheter which is smaller than 3 French, it is known as a micro catheter. So anything larger than 3 French is a normal guiding catheter, and anything less than 3 French is a micro catheter. So now why we need a micro catheter? So aorta is a big thing. We can insert a sheaths. Celiac axis is again, as we go from center to peripheral, the vessel size in decreases. So we need also a hardware which is compatible to that vessel size. So as we go more and more distal, if we want to go to the jejunal artery and to the vasa recta, we will be needing a very small catheters which are like 1.7 French, or maybe even smaller catheters are available. So we need a smaller catheters to reach for a distal cannulation. So anything lesser than 3 French is known as a micro catheter. So what we know is 3 French is equal to 1 mm. So anything less than 1 mm, anything less than 3 French is small micro catheter. It coaxially goes from our guiding catheter. So anything we take a catheter, we hook a celiac axis. From that particular catheter, we remove the guide wire and now insert a micro catheter. So we will be discussing these kind of things, how actually these are being used in case to case or clinical basis will be shown in due course. And these micro catheters fit coaxially, and we also have this micro wires. Again, 3 French will accept 018 wire. Now this 018 guide wire will guide this particular micro catheter. Now coaxial, we have understood one thing goes from the another thing, it is known as a coaxial. So this coaxially fits into a guiding catheter, and this micro guide wire guides this micro catheter to the very distal most positions, and we can navigate from SMA to jejunal artery to even at the level of vasa recta. So we can reach precisely super selectively into the arteries and do our interventions. If we want to do a TACE for a HCC, we can advance our microcatheters just at the origin of our tumoral feeding vessel, and we can insert our embolizing agents and the chemo emulsion to selectively fill the tumor, and rest of the liver can be saved from the side effect of this chemotherapeutic agents. So we need smaller catheters to have a very distal approach and very distal super selective cannulation. So again, these are have everything almost similar to the guiding catheters. These are of the various sizes and character based on their stiffness, their braiding, their flow rates, how larger material can be inserted, their hydrophilic coatings. So this is one of the most commonly used microcatheters. This is a pro-grade microcatheter. It accepts a 021 guide wire. It is a 2.7 French catheter, and this can be taken from this our main catheter. And microcatheter allows embolization with coils, with PVAs. Again, compatibility is a very big issue. We will be discussing about our embolic agents also. So if we want to go for a bronchial arteries, we want to use a PVA particle of 500 to 700 size. So these generally go from a 2.7 French catheter. But if we want to go for a prostatic artery and we want to use embolic material like of 100 to 300 PVA particles, so they can be even taken up from a very small. So 1.9 French catheter can accommodate 100 to 300 or 300 to 500, but 1.9 French cannot accommodate 500 to 700 of PVA. So again, we cannot use a 1.9 French for a bronchial artery. So again, we need to know our target area of interest and what material we are going to use. The compatibility has always to be matched for everything. For starting from the needles to micro catheters to our embolic agents to our stents to our plug sizes, whatever we are going to use with our interventions, the compatibility should always be there. Starting from the needle to sheath to guiding catheter to micro catheter, everything should be compatible enough. So guiding catheters designed to make a selective catheterization and intervention easier and help position or stabilize catheter when they are difficult to reach selectively. So again, we have a micro puncture set if we want to have access from a very small arteries like pedal, or we can want to have a radial access, or we want to puncture a very small needle. So we use a 21 gauge needle. It is a smaller caliber, and similarly, 21 gauge needle will have a smaller cope wire like access wire which is a 0.18 inch. It is not a 0.35, and then simultaneously we can insert a dilator over this guide wire. Now this dilator can accommodate a larger wire also, and similarly we can upgrade our micropuncture to a 0.18 from 0.35 system. So depending on our requirement, to start with we can have a normal 18 gauge access needle or a 21 gauge or micropuncture access needle. So giving a basic about our these are kind of the balloons which are used for sequential angioplasties or dilatation. So these balloons, this is a kind of 0.35 compatible. Again, this tip, this is a 0.35 guide wire which is coming out from this tip. So this has to be compared. If this balloon is 0.18 compatible, so we have to use a 0.18 wire. Now, if we are using a 0.35 wire, we need to use a 0.35 balloon. So again, compatibility for balloon is also there. So this is a kind of a long balloon which has a two ports. From this, we have a guide wire which is entering from here, exiting from here, and this port helps to inflate this tip. And this is a radio opaque distal marker, so which is guided. These two distal markers are radio opaque, and we see these markers on our DSA. So these can be simple balloons, which is this one. This can be drug-coated balloons, which are sirolimus, paclitaxel. Drugs are coated over it so as to have a better results as per the studies. These are the basics of the stents, which will be discussed according to the area of discussion of the topic. What we are using stents are of the various kinds, which can be uncovered stents, which do not have a PTFE coating, and these are the metallic stents. This is a metallic stent with a PTFE coating. Now, the where we use uncovered stent is if we just want to dilate it, and supposedly we have a narrowing at renal artery or aortic level or SFA, and be it anything. So we have a narrowing, and there are multiple branchings which are arising. So this do not have any side covering. So these branches still tend to get the blood flow, and these can drain into this stunted segment of the main vessel. So these are the uncovered stents. This can be used in arteries, veins, biliary system, and this is a covered stent. So covered stent, it does not allow blood to come from outside to inside, and it also does not allow blood or any material from which it is intended to use from going from inside to outside. If used in a biliary system, it does not allow. If it is placed in a CBD, it will not allow a cystic duct bile to be drained into this stent. So we prefer to use an uncovered stent in this kind of scenario. In covered stent, if we do have an aneurysm outside and we want to cover it, so we will place a covered stent. So we do not want the blood to go to the aneurysm, and we also do not want the aneurysmal blood to come back. So in these scenarios, we will place a covered stent. Again, we will place a covered stent like in a tips or mostly in the aneurysms. Rarely we place covered stents for other causes, but there are multiple indications. And another, again, stents are again of two types apart from uh, covered or uncovered. These can be self-expandable stent, and this is the self-expandable stent, which is which is constricted over a sheath. So again, this is a kind of 0.35 compatible stent. So a guide wire can be inserted from this hand hole, and stent is guided over this guide wire, and the sheath is slowly withdrawn back. As we withdraw the back, the stent automatically expands to its predestined diameter. So if it is a 10 mm stent, it will go up to the 10 mm automatically. compared to the balloon mounted stent. Now, what is a balloon mounted stent? It is a stent which is mounted over the balloon. Now, with this, we have this balloon, and this stent is mounted over it. So, balloon mounted stent is differs from self-expandable stent, is that we precisely inflate the balloon, and how much the balloon is inflated, the stent is going to expand to that much only. It will not self. If it is a 7 mm balloon, 7 mm balloon, and we at the time of inflation, we just inflate the balloon up to 5 mm depth, width. The stent is going to expand up to 5 mm only. It is not going to automatically go up to the 7 mm or 8 mm. However, compared to the SEMS, which is a self-expandable stent, it is just the sheath is withdrawn and the stent is going to come to its original size as before, which is outside the body. So these are kind of the basic stunts, balloons, needles, guide wires, sheaths. What is the French? What is the gauge? And how the compatibility is matched? What is 0.35 of inch? How's the end catheter size? So this is kind of a basic hardware which we need to understand before initiating our ABC of intervention radiology. And this hardware is very, very important. We have a basic knowledge of this. So this is almost very basic class which is depicting this hardwares, and there is a lot of new, lot of advanced hardwares, lot of modern things which are coming, which we intend to discuss and cover along with the topics uh, in the future. So thank you. If you have any questions or doubts, you can always reach out to me. Thank you.